Ebstein's anomaly. First described in 1866, Ebstein's anomaly refers to myopathy of the right ventricle that results in a variable degree of failure of delamination of the tricuspid valve leaflets from the underlying myocardium. This congenital malformation of the TV and RV is characterized by five key anatomical features: failure of delamination that results in adherence of the tricuspid valve leaflet to underlying myocardium, preferential delamination of the anterior leaflet with downward displacement, dilation of the atrialized RV, redundancy and fenestration and tethering of the anterior leaflet, dilation of the true atrioventricular junction. The atrioventricular node and the conduction systems are in their normal position. Functional RV impairment and incompetence of the deformed TV impede forward blood flow through the right heart. Furthermore, the contraction of the right atrium leads to distension of the atrialized RV, which acts as a passive reservoir, and this further decreases the volume of the right ventricular blood ejected. Moreover, the contraction of the atrialized RV during the ventricular asystole creates a pressure wave that impairs the venous filling of the RA. In most cases, the interatrial connection allows the right to left shunt and may also be bidirectional. The cumulative effect of these structural anomalies is cross RA dilation and leading to further incompetence of the TV widening and the interatrial communication. The severe forms of this anomaly lead to pancaking and compression of the left ventricle, atrial tachyarrhythmias, and signs of the ventricular pre-excitation. Wolff-Parkinson-Whites are common, and the patient with end-stage heart failure may have ventricular arrhythmias. In neonates, the normally occurring elevated pulmonary arteriolar resistance accentuates the degree of the tricuspid regurgitation, resulting in the elevated RA pressures and a profound right to left shunting. The severe right-sided heart failure and cyanosis may develop. In addition, the low cardiac output may result from the paradoxical septal motion and malposition of the interventricular septum. The degree of the cyanosis and heart failure may diminish as the fetal pulmonary hypertension regresses. While the chest X-ray typically demonstrates profound cardiomegaly, echocardiography remains the standard for establishing the diagnosis. In addition to evaluating the degree of TR and lamination of the tricuspid leaflet, size of the tricuspid annulus, RV size, ASD size, and shunt, echocardiography allows the assessment of the right ventricular outflow tract to ascertain whether there is anatomic or functional pulmonary atresia. Echocardiography also allows calculation of the Calimeric index, Great Ormond Street echocardiography, or GOS score. ECG may show additional evidence of the right-sided chamber enlargement, supraventricular arrhythmias, and signs of ventricular pre-excitation. That is Wolff-Parkinson-White syndrome. In children and adults, symptoms include fatigue, decreased exercise tolerance, dyspnea on exertion, cyanosis, and palpitation. The systolic murmur and TR may be heard, and there is a wide splitting of both first and second heart sound. When the advanced right heart failure is present, palpable liver enlargement, ascites, and peripheral edema may be noted. On the chest X-ray, the cardiac silhouette may vary from most normal to typical Ebstein globular shaped heart with a narrow waist. As before, echocardiography remains the diagnostic modality of choice and is instrumental for preoperative planning. Of note, the principal echocardiographic characteristic that differentiate Ebstein from other forms of congenital TR is the degree of the apical displacement of the septal leaflet from the crux of the heart. Is more than 0.8 centimeters. A newer adjunct being utilized for functional anatomical characterization of the Ebstein anomaly in the cardiac MRI, and this functional imaging modality allows for the characterization of the normal details and characterization of the RV function, which can help in determining the reconstructive strategy and the operative approach. The neonates, one has to investigate the cyanosis and medical therapy, and the ratio of the TR and severity should be assessed. Management of the neonates with the Ebstein's anomaly depend on the degree of the type of the pulmonary obstruction and LV function. Neonates with the antegrade pulmonary flow and the tricuspid valve leaflet anatomy favorable for the repair, including the large mobile anterior leaflet. Neonates with anatomic pulmonary atresia typically undergo univentricular strategy. Among the infants with functional pulmonary atresia, biventricular repair can be performed in a stable patient and mobilize the anterior leaflet. Neonates with poor LV function may require cardiac transplantation. Surgery is indicated when there is a presence of symptoms of the heart failure, paradoxical embolism, progressive cardiac enlargement, and appearance of arrhythmias. Biventricular repair is possible for the vast majority of the patient. A typical surgical strategy involves closure of any atrial septal communication, TV repair, and TV replacement, selective plication of the atrialized RV, performance of the indicated antiarrhythmic procedures, and the right reduction annuloplasty and selective plication of the bidirectional Glenn shunt. Although numerous TV repair strategies have been proposed over the years, the Selva cone reconstruction has become the valvuloplasty of choice. For selected patient, a Glenn shunt may be added. 1.5 ventricle repair indication include the significant RV dilation and leftward shift of the IVS, severe cyanosis, TV repair with a small resultant effective orifice to reduce the hemodynamic stress on a more complex multiple suture lines. TV repair, the need to proceed Fontaine procedure is almost never indicated. The cardiac transplantation is reserved for the patient with severe biventricular failure. Thank you.